Hello, everyone. All right, good afternoon, and thank you for taking the time to join us for our report release of Caregiving in a Diverse America, beginning to understand the systemic challenges facing family caregivers. My name is Dr. Vaughn Cochran, and I'm the Hunt Research Director for the National Alliance for Caregiving, as well as your moderator for this afternoon. I'm a nurse scientist with over 15 years of experience in dementia family caregiving research and related activities, incorporating a health equity lens. Today's webinar will be recorded and will include some welcoming remarks, an overview of the report analyses and findings, as well as discussion of current related research. We invite you to ask questions using the Q&A function throughout the afternoon, and we will have dedicated time at the end for questions and an engaging discussion toward action. And it seems like everyone is already starting to jump in and say hello from wherever you are, and we encourage you to continue to do that. We'd love to know our audience. We have a very robust group today of 334 registered participants, so welcome everyone. We are so glad you're here. So we're really excited about our speakers, and as we open, we'll begin with some words of welcome. And with that, I'll introduce our two welcoming speakers. Michael Whitkey joined the National Alliance for Caregiving in 2016. He serves as the Vice President for Research and Advocacy and is a senior member of NAC's executive leadership team. He supported the organization's growth during a leadership transition and has expanded capacity within NAC's research and advocacy departments, focusing on bridging gaps between data and policy to address challenges facing family caregivers of older adults, people with disabilities, and those with serious or chronic conditions across the lifespan. Jeanette Schultz is Director of Health Equity and Advocacy Relations at Amgen. In her role, Jeanette leads Amgen's health equity platform across the organization, including partnering with functional teams to align Amgen's health equity objectives, metrics and partnerships, and connecting this work to Amgen's environmental, social, and governance commitments. In addition, Jeanette spearheads the enterprise-level engagement strategy with the advocacy community at the above brand level, including building and sustaining relationships with the patient advocacy community with a primary focus on issues affecting equitable health. She holds a BA from the University of California, Santa Barbara, with a double major in communication and sociology and a master's in public health from the University of California, Los Angeles. And now I'll turn it over to Mike Whitkey, followed by Jeanette Schultz.
Thank you, Dr. Cothran. Hi, everyone. Thank you for joining us as we continue to facilitate a conversation on the topic of family caregivers in a diverse America. Late last year, NAC released a report covering secondary analysis of caregiving in the US 2020 data with the aim of beginning to understand the systemic challenges facing family caregivers. As Dr. Cothran mentioned, the purpose of the event today is to go into depth on the findings of the report, particularly around what we found to be some limitations in the data we analyzed as we're planning a follow-up to this effort. In addition to hearing about the report, we'll also cover family caregiver perspectives, the collaborative working relationship we have developed with the Diverse Elders Coalition and some of the work they have led, and insights from others leading work in the field of family caregiving. At the end of the presentation, we would like to have a dialogue with you so we can gain further insight as we work to ensure that we move together as a field to be more inclusive of caregivers in our richly diverse country. I would especially like to recognize those who made this work possible, including our sponsor, Amgen, our partners from the Diverse Elders Coalition and the National Minority Quality Forum, and the NAC team. On that note, I'll turn it over to our friend and colleague, Jeanette Schultz with Amgen, to say a few welcoming words. Thank you.
Thanks, Mike and Dr. Cothran. Hello, everyone. I'm Jeanette Schultz, and as Dr. Cothran mentioned, I'm the Director of Health Equity and Advocacy Relations at Amgen, and I'm so pleased to be a part of today's webinar. Amgen, if you don't know it, is a global biotechnology company that's committed to unlocking the potential of biology for patients suffering from serious illness by discovering, developing, manufacturing, and delivering innovative human therapeutics. Amgen's been around for more than 40 years and has a deep commitment to science and innovation that has helped patients live longer and healthier lives. Our mission at Amgen is to serve patients. We believe we have the responsibility and privilege to not only impact the health of just our patients, but also improve the world in which they live and enable everyone to live their healthiest life, regardless of race, ethnicity, or socioeconomic status. We approach health inequities recognizing that we are part of a broader community. We seek to be a strong partner, bringing our voice, resources, and diverse collaborations to advance bold initiatives and policy changes that address unfair and avoidable differences in health. Together with like-minded partners, we're committed towards working towards solutions that give rise and learn from historically underrepresented voices that need to be heard and expanding the reach of better health outcomes that everyone deserves. Our support of the National Alliance for Caregivers report that we will discuss today is one such example of that. This report marks an important first step in a better understanding the unique challenges of caregivers. And the findings make it clear that addressing the needs of caregivers is a critical part of achieving a future in which all Americans are able to receive equitable health care regardless of background. What's more is that this report expands the data set to understand the diverse experiences of family caregivers and, more importantly, the policy recommendations that lead toward lasting change. As the report calls out, programs need to be designed to reach those that they intend to serve, and we need to ensure that those services are provided in line with personal and cultural and ethnic preferences. Thank you again to the NAC team, including Dr. Cothran and Mike Whitticky, as well as Mike noted, our important partners, the Diverse Elders Coalition and the National Minority Equality Forum. And finally, to the advisory committee that all played a role in an instrumental role, in the development of this important report. Amgen's so proud to support this dialogue today, and we look forward to hearing all of your thoughts.
Thank you to you both. Now we'll have some caregiver insights. Ray Costosiano is the founder and executive director of Table Wisdom, an award-winning social enterprise that brings together older adults and younger foreign-borns for meaningful conversations online. His Filipino-American immigrant and caregiving experiences for his parents inspired him to create it. Before relocating to St. Louis to be a caregiver, he worked in the biotech industry in Los Angeles. While caregiving, he led the program's reach from 1 to over 50 US cities and 23 international cities. It's been recognized for innovation with a top 5 national finish for the Encore Prize and has won an award from the Washington University in St. Louis, Brown School of Social Work, or WashU Brown School of Social Work. His work is in the #1 Wall Street Journal book on aging well, How to Live Forever, the New York Times, CNN Health, and other outlets. He's also a Public Voices Fellow of the Op-Ed Project and a Care Fellow of Caring Across Generations. He has degrees from UCLA and USC Marshall School of Business and a social entrepreneurship certificate from WashU Brown School of Social Work. With that, Ray, please.
Thank you so much for that wonderful introduction. I'm actually very familiar with Amgen. When I was still in LA, I actually worked literally 2 minutes away from its office. So come full circle. So first off, I'm gonna talk a little bit about myself on how I became a caregiver. And then I'm gonna talk about some of the items that resonate with me from the report. So as mentioned, I'm a Filipino-American immigrant from the Philippines. Arrived here in 1989. My parents were both professionals in my old country. And when coming here, my parents had to start from scratch. My dad, he was a lawyer. He worked as a security guard. He couldn't get into the legal profession. So I'm very much aware of some of the sacrifices my parents made. And I mention those things because ever since I was young, we are very much influenced that we are to take care of our elders once we grow older, or in the report, it was referred to as filial piety. So but I'm blessed, I got my degrees here from UCLA USC. My trajectory was going to biotech, But in 2014, I spent 6 weeks in a nursing home when my father had a stroke. I was there 7 days a week, 8 hours a day. And when my father got discharged, that's when I decided to relocate from LA to St. Louis to become a caregiver. So with that, I'm just gonna speak a little bit about some of the things that connected with me in the report. So with regard to the living situation, I had to move in to my parents' home, take care of my father's ADLs and IADLs, helping provide meals and transportation. I spent about 25 hours a week as a caregiver. In terms of information that we received from the medical providers, it was really difficult for us to get them, but we are fortunate because my parents can understand the English language. So I understand that a lot of the Asian American caregivers or their care recipients may not be as fortunate. Regarding future planning, we have discussed future plans with my parents. If I ever move back to Southern California, they come with me. Maybe we'll have one of those granny flats next to our house so that we could be close to them. So that's pretty much it. In closing, I think this is a great start to having awareness to the different needs of caregivers and opens up a door for more robust and nuanced conversations as we move forward with understanding the needs of diverse caregivers. And I certainly hope that other companies will follow suit what Amgen is trying to accomplish in improving access to healthcare equity. Thank you.
Thank you so much, Ray. Hearing the caregiving voice is central to our mission and further contextualizes this work. Thank you again. Now we'll have some remarks from one of our partners. Lauren Pongen serves as the National Director of Diverse Elders Coalition, a coalition of 6 national aging organizations that advocates for policies and programs that improve aging in our communities as racially and ethnically diverse people, American Indians and Alaskan Natives, LGBTQ+ people. Before coming to DC, she worked to support and build a national network of health equity leaders from Asian American, Native Hawaiian, and Pacific Islander communities through the country. Lauren identifies as a mixed race, second generation Filipino American. Lauren? You're on mute.
Literally, like how many months of Zoom before? Sorry, everyone. Y'all know how it is. Good afternoon, everyone. As Dr. Cawthron mentioned, my name is Lauren Pongen. I'm the National Director at Diverse Elders Coalition. And really quickly, I just wanted to thank Ray so much for sharing his story. It really resonated with me. I'm also Filipino American, and I often share our family's caregiving story about my grandparents having to move back to the Philippines after spending most of their adult life here in the US. And now my dad is reaching that age too, and watching him and all of his siblings sort of have to face similar choices and make the same decisions about which country to stay in due to availability and affordability of care. So really brings all of this report and the importance of it back home, why we're gathering this data. To introduce the coalition, I know all of you will hear from Dr. Yenira Cruz a little bit later on, but just really wanted to highlight some of the members of our coalition who are listed in this slide: NAPCA and CBA, the National Hispanic Council on Aging, National Indian Council on Aging, SAGE, and CRAC. For their important contributions. Together as a coalition, we really advocate at the intersection of equity and aging. And over the past maybe 4 or 5 years, caregiving's really come up as an important issue, as of course, not only are we seeing more diverse folks aging, but also understanding how the health and well-being of caregivers for older adults really does impact the health outcomes of older adults themselves. So when we were reached out to by the National Alliance for Caregiving, we have a longstanding relationship, and we were really excited to be a part of this report. In this partnership, like I mentioned, our work is at that intersection of equity and aging, but we've always appreciated National Alliance for Caregiving's kind of eagle eye lens. They help us bring expertise from around caregiving across the lifespan, paid and unpaid, and really help to bring those perspectives and merge the equity lens that we bring with their own equity lens, of course, but also just to create a broader context for how this work moves forward. It was our pleasure to collaborate on this report, and especially working through what we know is some of the data limitations and helping to identify in further and future work where we should and will allocate resources to provide more robust data sets for folks who are underrepresented. The National Alliance for Caregiving also partnered with us on a secondary report around family caregiving, just to kind of make sure that what we've been hearing from folks in the COVID space and the impact on family caregivers gets heard by decision makers, policy makers, and just to keep and continue to share caregivers' personal stories and how it impacts them in daily life and in real concrete ways. So just want to, bring home that thank you for this collaborative effort to Amgen, to the National Quality Minority Health Forum, and to National Alliance for Caregiving for allowing us to participate and partner on this. And we hope to continue this partnership moving forward.
Thank you, Lauren. We're very grateful to you and our other partners who've worked with us. Now with that, we'll move right into the report itself, and we'll begin discussing the analyses and findings. Dr. Mosumi Bose is the mother of Ilan Betzer, who was born with Zellweger spectrum disorder, a rare, life-limiting genetic disease. As a result of her personal experience with her son, Dr. Bose refocused her career goals to study rare disease. Over the last several years, Dr. Bose has conducted research and published multiple papers on the role of the family caregiver in the management of rare pediatric disorders. She also served on the advisory committee for the 2018 Rare Caregiving Study sponsored by the National Alliance for Caregiving. Currently, she holds a faculty position in the Department of Nutrition and Food Studies at Montclair State University in New Jersey, studying quality of life in rare disease patients, caregivers, and families. Dr. Bose is passionate about learning what is important to rare disease families and using that information to improve their lives. We are grateful for Dr. Bose's willingness to pick up this work that was started earlier to help organize and frame the findings. Reed Bratches is a PhD candidate at Dartmouth College. Reed completed an undergraduate degree in political theory from Franklin and Marshall College, a master's degree in cultural studies, and a master's of public health from the Dartmouth Institute of Health Policy and Clinical Practice. Reed's PhD work focuses on understanding the experience of family caregivers, designing interventions to support them, and optimizing how we communicate clinical information to family members. Outside the office, Reed enjoys golf, cycling, and trying to wrangle his 6-month-old son. Dr. Paul Barr is an associate professor in the Dartmouth Institute for Health Policy and Clinical Practice and the Center for Technology and Behavioral Health, with advanced training in quantitative and qualitative methods. He received a Bachelor's of Science in Psychology, a Master's of Science in Public Health, Health Services Research at the London School of Hygiene and Tropical Medicine in England, and a PhD in Health Services Research from Queen's University in Belfast, Ireland. Paul's research involves developing and evaluating measurement tools and interventions to strengthen shared decision-making and improve the communication of medical information with patients and their families. His recent work includes the development of a decision support tool for individuals with depression in collaboration with the Mental Health America, with the goal of increasing mental health literacy and improving access to online evidence-based treatments. Paul is a Gordon and Betty Moore Foundation Patient and Family Engagement Awardee. Through this award, Paul formed the Open Recordings Research Group, openrecordings.org, a multidisciplinary group of stakeholders, including patients and caregivers who study the potential clinical utility of recording information about healthcare clinic visits. Outside of work, Paul can be found chasing his 2 children up mountains and trying to keep up as they ski back down, coaching their soccer team, teaching science at Mount Lebanon Elementary School as part of the Four Winds program, and making furniture in the Dartmouth woodshop. Reed will be presenting on his behalf with them today. Sumi and Reed, please take it away.
Thanks so much, Dr. Cothran, and thank you so much for that really nice introduction. I'm so glad to be here today, and I loved hearing the stories of caregiving with the previous speakers, because I really feel like those stories bring life to data as what is presented, that we're going to present here in the report. As was mentioned previously, I came into this project after it was started. And so when I came in, the data and the analysis had already been done. One of my major tasks and one of my first tasks here was to organize the findings for this report. So what I did with the help of this just incredible team with Lauren and Mike and our collaborators at Dartmouth was put it together in a way so that each of the underrepresented groups that were included in this analysis were given an individual chapter in the report. And by doing this, what I wanted to be able to do is to provide a rich characterization of their experience within the context of the outcomes that we studied in this analysis. And it also allowed us to identify points of intervention that are specific to this group. I should disclose, though, in the interest of trying to highlight some of these disparities, for each of these chapters, we did have a reference category. And in the case of the different racial and ethnic groups that we looked at, our reference category was non-Hispanic white caregivers. With our chapter on the LGBTQ population, a reference category were individuals that identified as not LGBTQ plus caregivers. And then for the comparison between the rural caregiver experience, a reference category were caregivers that identified, that stated that they lived in, that they cared for a recipient in an urban area. So just to provide a little bit of a context there. The overarching research question here was, do caregivers identifying with different diverse backgrounds, which includes race and ethnicity. We looked at income level, LGBTQ status, as well as geographic location. Do they experience different outcomes with respect to their caregiver role? So broadly, we looked at outcomes related to a caregiver's living situation, their tasks and their time and their hours spent, self-reported health, both physical and emotional, as well as financial impacts. And we know from the earlier caregiving in the US 2020 reports, family caregivers spend over $500 billion a year in costs associated with providing care. So what I'm going to do is just give you a brief snapshot of what is in this report, because there is a lot of information in this report, and we only have a little bit amount of time, but we'll be happy to take any additional questions at the end of this discussion. So next slide, please. So I'll start just talking a little bit about the individuals that participated in this study. As stated before, this was a secondary analysis using the data set from the Caregiving in the US 2020 report. And in that particular study, we had over 1,300 participants take part in the survey. And what you see here is in relation to what our research goals were for this particular secondary analysis is the sort of breakdown of the participants by these different diverse groups that we were looking at. And what you can see is that, as is the case with participation in a lot of research currently, thankfully it's been addressed, and it needs to get better. But the sample here is predominantly comprised of non-Hispanic white participants, and this is a limitation of the study, but this is a secondary analysis. And I think what we have highlighted here is that this is an important first step to help pave the way for future studies that look at these topics a little bit more intentionally and as their primary research goal. Next slide, please. So what I'm going to be doing is just giving you just again a brief snapshot of each of the chapters that we included here in this report. And one of the first groups that we discussed were African American caregivers. And what we found is that compared to non-Hispanic white caregivers, more African American caregivers live with their care recipient. They provide more hours of care. When looking at overall self-reported health, less African-American caregivers report that their overall health as good or excellent. One of the really interesting findings that we got from this data analysis is that despite what seems like the sort of increased burden of African-American caregivers, and this includes financial impacts, which I've listed on the next slide because there just wasn't enough room in this slide. African-American caregivers report in this study that caregiving, despite all these burdens, gives meaning to their lives, and more African-American caregivers report this compared to non-Hispanic white caregivers. This is not the only group that we see this phenomenon in, and I'll talk about that throughout the course of this talk. Next slide, please. So as I said before, part of this increased burden involves financial impacts, and we see that more African-American caregivers have these financial impacts, including taking on more debt or filing for bankruptcy, more so than non-Hispanic white caregivers. So that's just, again, a brief snapshot. I'm going to move on, and again, if you have questions, we'll be happy to discuss them in the end. So next slide. Where we will talk about the next chapter, which is focusing on Hispanic and Latino caregivers. And what we see is similar to African-American caregivers. More Hispanic caregivers live with their care recipient. This study also found that Hispanic caregivers experience greater caregiving intensity, and that caregiving intensity is a function of the type of tasks performed as along with the number of hours spent on these tasks. They experience more financial impacts. Another thing that we found is that related to overall health and healthcare, Hispanic caregivers, more Hispanic caregivers lack health insurance, and less Hispanic caregivers report being in good or excellent overall health. Again, despite these findings, we also see that Hispanic caregivers report, more Hispanic caregivers report that caregiving brings meaning to their life compared to their non-Hispanic white counterparts. So next chapter, next slide, please. Looked at the experience of Asian American and Pacific Islander caregivers. And again, we see that more AAPI caregivers live with their care recipients compared to non-Hispanic white caregivers. Less AAPI caregivers report that their overall health is good or excellent compared to non-Hispanic white caregivers. And in terms of financial impacts, we see that more AAPI caregivers have had to take on a second job or look for additional income, as well as AAPI caregivers are less AAPI caregivers have future plans in terms of caregiving in place for their care recipient. This particular finding may be an issue related to access to resources, as Ray had mentioned, and communication with medical care providers. And I know that Paul and Rita are going to be addressing this in their part of this conversation. So we can continue that in this part of the discussion when we go to questions. Next slide, please. So we had a chapter on looking at the experience of LGBTQ caregivers, and what we found is that compared to caregivers that did not identify as LGBTQ, LGBTQ caregivers were more often the primary caregiver for their care recipient and the sole caregiver for their care recipient. And in that, these caregivers assist with more activities of daily living. More LGBTQ caregivers report being in poor health compared to non-LGBTQ caregivers, and this may be related to their caregiving living situation and the fact that they're the primary and sole caregivers for their care recipient. But many more LGBTQ caregivers report feeling alone in their caregiving responsibilities, and I'll sort of address this at the end when we get to the conclusions. The last group I'm going to highlight today as part of this report are caregivers that care for recipients living in rural areas. And as I said before, the reference group here were caregivers that care for their recipients in urban areas. And we found that more caregivers that live in these rural areas are required to perform medical and nursing tasks for their care recipient compared to those living in these urban areas. And additionally, these caregivers have more financial impacts compared to caregivers that are from an urban area, which includes taking on more debt, not being able to pay bills, as well as being unable to save compared to caregivers that live in an urban area. So again, just a very quick snapshot of what we covered here in this report. So I'll just come with just a few conclusions, which will be the next slide, please. So one of the things that I think was a big sort of takeaway here is that that caregivers from diverse backgrounds, especially when looking at race and ethnicity, we're looking at our African-American caregivers, our Hispanic caregivers, and our AAPI caregivers, more of these caregivers live with their care recipients. Now, I'm a total researcher and not a policy person at all, and I will let Dr. Cothran and Mike sort of handle that. But information like this may provide evidence that when we're looking at allocation of resources and funding, we need to focus on caregivers and their care recipients where they are, which seems to be in their home as opposed to outside facilities. These disparities that we see across these certain groups with respect to task burden, as well as financial impact, we see disparities in all of these groups compared to the referent category. So there needs to be future research that is focused on teasing out what are the contributors to these disparities. One thing that I want to also highlight is that the LGBTQ caregivers, as I said before, they tend to be the primary and sole caregivers for their recipients, and they often feel quite alone in their responsibilities. Something that I didn't show here explicitly, but was in our findings, is that more LGBTQ caregivers, they live without a partner and children, so this may have an impact on their caregiving responsibilities, but this may also speak to continued systemic bias towards familial structures within the LGBTQ community. And then lastly, despite some of these disparities, we saw that some groups, and maybe despite is not really the appropriate word here, but in some groups, particularly in the African-American and Hispanic communities, caregivers reported finding meaning in their caregiving responsibilities more so than our referent category, which were non-Hispanic white caregivers. And I know that Reed's going to briefly cover some of the sort of psychological impact among groups with his analysis. But I think what I want sort of one of the big takeaways to be here is that this really hammers in why this type of study is needed. Not only can this research identify disparities that should be addressed, but it may also identify experiences and perspectives that seem to be perhaps beneficial to these caregivers in these diverse communities, but may also be tools that all caregivers can use to help to try to better understand their role and better cope with their experience of being a caregiver. All that being said, there is some existing literature that challenges these sort of findings about, caregivers, being more, finding more meaning in their caregiving role. Some of these studies will suggest that these types of findings may be more of an artifact of the study. And that also highlights, again, the need for more intentional, specific research in this field to better understand the experiences of caregivers from diverse backgrounds. I'll finish with just a few limitations, and then I'll pass it over to Reed. So this was a secondary analysis. So the research question that we have the research question that we had, it wasn't developed with it was developed after the data collection strategy was developed. So, there needs to be more primary research here in this sort of space. The study design, the way that it is, cannot account for issues such as intersectionality between these across these underrepresented groups, nor is it able to understand the sort of segmentation of these within these individual groups that were studied. What I'm presenting here is a descriptive analysis, and I can say that there is this relationship between, say, race and ethnicity and some sort of caregiving outcome, but there's we're so much more than these individual things that we identify with, and it's the same with research. There's a lot of variables here, and the way that this data is presented does not necessarily account for these other variables that may confound some of our findings. And that's really why we have our partners at Dartmouth to do this logistic regression analysis. I'll end there saying that we need more research, and we can continue this conversation at the end of this discussion. Thank you so much for your time.
Hey y'all, my name is Reed, and Dr. Paul Barr is on the call as well. Dr. Bose, thank you so much for the run up and talking about the descriptive statistics. I'm going to talk a little bit about the findings of the logistic regression analysis that we did today. Lauren, next slide, please. So a little bit of background on why do a logistic regression. Well, we know that variation exists in the caregiver experience, but one of the big questions is what drives this variation. And the focus of this report is understanding whether caregiver identity could be driving some of this variation. Understanding what drives variation can help us to identify the high value areas that we can target with research and with policy that could make the biggest impact on the caregiver experience. Next slide, please. So why do logistic regression? Logistic regression is a statistical technique that allows us to see associations when controlling for variables that might affect the data and other outcomes in the data. It gives us a more accurate understanding of what the data says and helps us to understand the effect of different variables on the outcomes that we're interested in. Next slide, please. So here's just a quick logistic regression example so that we're all on the same page. Back in 2016, there was a paper that found that there was a statistically significant correlation between drinking coffee and developing lung cancer. They found that compared to non-drinkers, having at least 1 cup of coffee per day was associated with a higher risk of developing lung cancer. And they concluded with the question, should we all stop drinking coffee if it's going to give us lung cancer? Next slide, please. Now, that was just a descriptive analysis of the studies that were out there. In 2018, another group of researchers looked at the same data and found that when controlling for smoking cigarettes, coffee is actually protective for lung cancer. And they found that drinking 1 to 2 cups per day is actually associated with a lower risk of developing lung cancer. And multiple logistic regression, which is the technique that we use here as well, helped them and helps us to see the signal of what the data is saying through the noise of all of the rest of the data set. Next slide, please. So as was mentioned previously, the research question for this particular analysis is, do caregivers of diverse backgrounds, as defined by race, ethnicity, income, and LGBTQ status, experience different outcomes with regard to strain, level of caregiving intensity, ADLs and IADLs, and resources used? Next slide, please. So what did we control for in this analysis? Well, we made the decision to control for caregiver gender, caregiver age, household income, and care recipient condition. And care recipient condition we defined, this is defined in the report as caring for a short-term physical problem, a long-term physical problem, an emotional or mental problem, a behavioral issue, or memory problems. Next slide, please. Now, with regression analysis, as Dr. Bose mentioned, we do need to make comparisons. And in order to make comparisons, we have to compare the results to something else. And when deciding which group to compare to, there are some rules that we tend to use. For groups with a defined order, like age and income, the best practice is to use a group on one end of the scale as the comparison group. So either the, in case of age, either the youngest or the oldest. For groups with no defined order, like race or ethnicity, the best practice is to use the largest group as the comparison group. And one thing that I'd like to make very clear is that the comparison group choice is not normative, and it doesn't imply that whichever group that we're using as the comparison group is doing it the right way, or that all the other groups should be doing it the way that comparison group, or the way of the comparison group. The comparison group is really chosen to maximize the precision and the interpretability of the results. And it allows for consistency in comparisons across different outcomes when we use the same comparison group in different analyses. Next slide, please. The comparison groups that we used for this particular analysis, for race and ethnicity, we used white non-Hispanic caregivers. We used an income level of greater than $100,000 for household income. And the reference category for age was 18 to 29 years old. Next slide, please. So what outcomes did we look at? We looked at caregiver strain, so physical strain, emotional strain, and financial strain, and we looked at those independently. We also looked at level of caregiving intensity, which, as mentioned, is a mix of, or it's a scale that is a mix of the number and type of tasks that caregivers use, as well as the time that those tasks take. We looked at ADLs and IADLs, and we looked at information and resources used by caregivers. Next slide, please. So what did we find? For strain, we found that caregivers that identified as Hispanic reported greater physical strain. And we found that caregivers identifying as Black or African American reported lower emotional strain. Next slide, please. We also found that caregivers of lower income levels reported higher emotional strain. And this was a stepwise comparison. So as income level decreased, emotional strain increased. We also found that chronic conditions all reported high levels of physical, emotional, and financial strain. Next slide, please. For caregiving intensity, we found that caregivers identifying as Hispanic reported higher levels of caregiving intensity. Next slide, please. And that caring for short and long-term physical problems were associated with increases in caregiving intensity. Next slide, please. For ADLs and IADLs, we found that caregivers who identified as Black or African American, Asian, or Hispanic reported a greater odds of managing medications for the care recipient. Next slide, please. And we also found that as care recipient age increased, there was an increasing odds of the caregiver managing medications. Next slide, please. As well as those who care for emotional managing finances. Next slide, please. And that as care recipient age increased, there's an increasing odds of the caregiver requesting information through the internet about the care recipient. Next slide, please. We also found that caregivers who identify as Black or African American or as Asian reported a lower odds of the provider asking them what is needed for their caregiving. Next slide, please. So a few limitations in addition to the ones mentioned by Dr. Bose. This was a cross-sectional study, so we can't determine causality because this was just taken from one report in one slice of time. More work really is needed to see what the causal relationship is between these variables. Next slide, please. But the main takeaways here are that caregivers who identify with minority groups need more support. There's a higher physical and emotional strain associated with caregiving in those groups. And there was a lower reported odds of providers asking them what they need to support their caregiving. We also found that the caregivers with chronic conditions reported higher levels of strain, both physical, emotional, and financial. And caregivers are increasingly turning to the internet for information as they age. So it's really important to make sure the information out there is good and useful for them. And that, I think we'll turn over to Fawn and Lauren.
Thank you so much. Thank you both for providing that overview of just the data that we had in the analyses as well as the findings. So now we'll move into lessons learned and implications for the future. So we'll hear from my NAC colleague, Lauren Tokorowicz, as well as myself. Lauren Tokorowicz is NAC's research manager and works with the Hunt Research Director to create the reports and guidebooks that are released yearly to increase public awareness on caregiving issues and to provide support to caregivers through data and recommendations based on this data. She is responsible for conducting the oral histories NAC uses to collect caregiver stories in order to understand on a more personal level the caregiver experience. Lauren has a Master of Library and Information Science from the University of Illinois Urbana-Champaign, as well as a BA in History and English from the same university. She is originally from the Chicagoland area and, true to Illinoisan stereotype, is a fan of the Cubs, hockey, snowstorms, and Abraham Lincoln. Lauren, and then I'll jump in after.
Hello, everyone. Thank you, Dr. Cothran, for the introduction. I am going to go over some of the limitations from this study and the lessons learned from those limitations and what we need to do to move forward. Some of these limitations have already been mentioned by Dr. Bose and Reed, but we'll kind of go more into what they were and how we want to move forward from this point. So as was mentioned, we were limited in the original survey data from Caregiving in the US 2020. This was a secondary report, so we could only analyze the data that was found for that report. And Caregiving in the US 2020 gathered data on non-Hispanic, white, African American, Hispanic, Asian American and Pacific Islander, and LGBTQ+ caregivers. So we did not have data on American Indian, Alaska Native caregivers, and we didn't have more detailed information on Asian American and Pacific Islander caregivers who cover a very broad range of ethnicities and languages, and more detailed information on LGBTQ+ caregivers who cover a broad range of identities and understandings of themselves. So on this lack of American Indian and Alaska Native data, the methodology used in Caregiving in the US 2020 impacted our ability to gather representative data on this population. And little research in the caregiving world in general has been done for American Indian and Alaska Native caregivers, it's important to do this research because their culture, their health, the role of their community, and the systemic inequities that have affected them need to be understood in order to support their specific needs. And it's important to understand caregivers in the American Indian and Alaskan Native communities because we need to address those needs in culturally responsive ways. So there are over 574 federally recognized Indian nations, and more than those exist. The community is diverse in and of itself, and there's no one size fits all solution. So it's also important to remember as we do research on this community that we can't, this is true of any caregiver, but we can't say that this, if we provide a solution, it will apply to everybody. There needs to be more understanding of specific solutions and culturally responsive solutions that and supports and interventions that we can give. So Dr. Bose mentioned earlier that there was a lack of segmentation and intersectionality in this report. Segmentation, as we've defined it here, are the identities that may exist within the larger groups that Caregiving in a Diverse America has defined. So we had the Hispanic population or the Hispanic community, but Hispanics can cover a wide range of languages, identities, and peoples. So a Mexican caregiver may have different needs and understandings towards caregiver or caregiving than a Brazilian caregiver or an El Salvadorian caregiver. African Americans may identify differently based on their history and their own experience. So some African Americans may want to be identified as Black based on their own experience, and some say that neither African American nor Black properly encompasses their identity and their understanding of their own culture. So there needs to be more work in addressing them the way that they want to be identified and understanding those identities. And then, as I said earlier, the Asian American and Pacific Islander community is made up of over 50 different ethnicities, and they speak over 100 different languages. So again, a Filipino caregiver can be very different from a Chinese caregiver, could be very different from a Polynesian caregiver. So there needs to be more research into those specific communities and their understanding of what they need as caregivers. And then the LGBTQ plus community is composed of various different identities that carry individual meaning to those people. So I know lesbian, gay, bisexual, and transgender are the most commonly recognized ones, but you can also be non-binary, demisexual, pansexual. There are many different identities that that should be addressed and talked to so that their needs are understood and met. Intersectionality, as we understand it in this report, is where the groups we have separated in the report may intersect, which create new cultures, identities, and understandings. So there could be intersectionality among the ethnicities in this report. Somebody who identifies as African American could also identify as Hispanic. So we do not have an understanding of, say, Afro-Latin caregivers or their needs. And then all the ethnic and racial groups explored in this report could have had individuals who also identified as a member of the LGBTQ plus community. So we could have had a Hispanic caregiver who was also gay, and we don't understand the specific experiences or needs of that caregiver because we block them off in either LGBTQ or non-LGBTQ, and then Hispanic or non-Hispanic, white, or another diverse community group. So moving forward, in order to better address the needs of these caregivers and to understand their needs and do better research moving forward, we need to ensure that we reach out to the communities that we want to support. So we need to engage members of these communities, community-based organizations within these communities, and local services that already serve these communities in future research. And we should fund research that is being done by members of these communities already. We need to continue work towards fostering equitable relationships so that the healthcare system and researchers are held responsible for the work that they do. We need to, from the beginning, develop research practices and methodologies that will allow for the inclusion of diverse groups. And we should also be conferring with these groups from the beginning on how best to conduct the research so that the research itself is culturally responsive and supportive. We need to keep in mind that both segmentation and intersectionality exist when developing research, and continue to research communities that are underrepresented or overlooked. So ultimately, we want to create an equitable and fair system that addresses the needs of caregivers, regardless of their culture, their identity, or their background. And now I'm going to pass it over to Dr. Cothran.
Thank you. Could you advance the next slide, please? Or next slide, please. Thank you. So I'll just say that this work is particularly important, not only because of my professional role, but also because personally, in terms of friends and family members who are navigating the varied caregiving journeys. Caregivers play an active and critical yet often invisible role. And without understanding the diverse experiences of caregivers, especially within communities of color, programs and intervention developments will be limited or even ineffective for various populations. And so for the last few minutes of our time for this segment, I'll just highlight a few these areas that I see where the work with future implications can move forward in research, policy, advocacy, practice, and programming. And some of the things have already been mentioned, but I'll just reinforce them. So in terms of research, we definitely need more research that includes mixed methods and team science approaches to address the complexities of caregiving. Culturally relevant recruitment and retention strategies is another mechanism that we need to focus on, because it's not enough for us to rely on narratives such as hard to reach populations. It's up to us to establish those mutual partnerships from the beginning, to plan appropriate outreach and engagement, and to invest the time and funding to support the infrastructure of community-based partners who directly serve and know their communities. In terms of policy, we need policies that guide federal funding priorities for caregiving research. And we need to enact policies that directly support caregivers based on evidence such as paid leave. For advocacy, we need to advocate for system change, centering perspectives that warrant closer examination and understanding in order for us to disrupt the status quo. For practice, we need to incorporate and empower caregivers as expert partners to enhance quality of life for persons living with chronic conditions. It's the caregivers who can help inform the realities and opportunities of the prescribed care regimens. And then finally, with programming, we need to offer tailored programs or materials in the preferred language of communities while taking into account varied language proficiency. We need to deliver the programs or materials in trusted environments or with trusted partner organizations. And we need to expand eligibility criteria. For example, family is not solely biologic, but it is an individually identified community of choice, and programs that rely on limited definitions are exclusive. And so with that, those are what I see as some of the areas of implications for the future from this report. And now we'll move into some specific comments from our next speaker about health equity and accessibility. Dr. Yanira Cruz is the president and CEO of the National Hispanic Council on Aging. She focuses on providing a Latino perspective on public health and older adult caregiver issues to increase policymakers and the public's understanding of the needs impacting vulnerable sectors of our society, while encouraging the adoption of programs and policies that equitably serve everyone. To further these efforts, Dr. Cruz serves on the Board of Justice and Aging, American Society on Aging, and is a member of the Leaders of Aging organizations. Dr. Cruz is also a founding member of the Diverse Elders Coalition and was named one of the top 50 influencers in aging by Next Avenue. Dr. Cruz received her Bachelor of Science in Biology and both her Master of Public Health and Doctorate of Public Health from the George Washington University School of Public Health and Health Services. Dr. Cruz.
Thank you. Thank you so much, Dr. Catherine, for that very nice introduction. And thank you to all the panelists who have gone before me. I think a lot of what I had to say has already been shared. I want to take a moment to congratulate the National Alliance for Caregiving for taking on this important work. I know it has been a long process, and you've dedicated a lot of time, energy, and passion to producing this very unique report that is very much needed in our community, in our society. I also want to just applaud the partnership where academia and the nonprofit sector has come together to produce this important work. So I want to say thank you for coming together and bringing your talents together. Is not always the case that academia works with the nonprofit sector. It's something that I'm very passionate about. And I think lots of good work can be done, can be produced on behalf of our communities when we come together. So thank you for both the academia sector and the nonprofit sector joining forces in this regard. So equity and accessibility in research. So, why is this important? Well, it's important because many groups, especially communities of color, women, LGBTQ+, older adult populations have been left out historically from research that we have, research that has been done. And we know how important research is for developing, clinical practices, for the development of medicines. And so we know that if we want to address inequities in our healthcare system, inequities in healthcare, we need to first start by making sure that our populations, all of our populations represented here today that are represented in the Diverse Elders Coalition, and Lauren spoke about this coalition earlier today, get included in the research work that is underway. So, and what is the problem that we have right now? We know that among our communities of color, LGBTQ+ populations, older adults, women, there is mistrust of the of research, and that mistrust is keeping our communities from participating as they should in this process. The mistrust that we see is has to be recognized and acknowledged. Science has failed many of our communities, and we don't have to go very far. I mean, just a couple of years ago at the detention center, many of the women who were detained there were sterilized without their consent. So, we have to continue to monitor research and researchers and investigators to ensure that we uphold our ethical standards and we protect communities, particularly vulnerable communities. In this case, I'm talking about immigrant women who were detained in the US-Mexico border. But that's just one example. There's many that we can talk about. So I think those are major challenges that we need to overcome. We need to address in our community. And what can we do about it? I mean, what can we do about it today? I think it is clear from the engagement that we have had with communities across the country that our populations do want to take part of research. When we take the time to explain to them why research is important, when we go into the communities with a respectful mindset, and not use them as subjects, but as important participants in the research equation, right? So I think we need to engage, we need to educate and mobilize diverse populations, LGBTQ+ populations to participate in research. We have come a long way, we have done a lot, but we're not there yet. We have a lot to do in this regard. There are important examples that we can highlight. The All of Us Research Project, for example, which is sponsored by NIH, is an example of a research project that a research effort that is working to engage more than 1 million people in a database to study, a large set of populations, including the diversity that is represented in our country. That's one example, and that's one that I applaud. But we need more of those type of efforts across our societies to be able to address health inequities in our world. I think we also need to train more researchers from our diverse populations. I think we need to tackle the pipeline. We need more African-American, Latinos, Asians, LGBTQ+ researchers out there. We need more of us in schools of medicines, in programs with PhD. More of us need to be there who can then go back and address some of the important research issues that need to be addressed. So I think we need to invest more in the pipeline, and I think we need to support more diverse researchers who are already prepared and ready. But so often, researchers representing diverse populations oftentimes have to compete so hard to win the research proposals, and so I think we need to go in there with an equity lens and figure out how we can support more diverse researchers, so that that works get supported. I think it's well documented that when communities of color get trained in a particular field, they tend to go back and help their communities. And I think this is something that we need to acknowledge and we need to leverage so that we have more of us out there working to address health inequities and just improve the health of our populations. So I think you know, in conclusion, I want to just say that we have come a long way. We have addressed some important barriers that we're facing to accomplish health equity in our communities. But I think we need to continue to work. We have a lot of work to get done in the days ahead. I think this is an important example that can inspire all of us to continue to do more of this type of work. There is just not enough data, not enough research done on Black and Brown communities, LGBTQ plus communities, older adults and women. And so I think I see this just as the beginning of an important effort to address health inequities in our society. I think the research piece is such an important ingredient in addressing access to healthcare for all of us. So with that, I want to just say thank you for inviting me and turn it over to our moderator.
Thank you. Thank you so much for sharing those very important insights. And now we'll wrap up our last section where we'll talk about current research in the field. So I'd like to introduce Dr. Meenakshi Raj, who is an assistant professor in kinesiology and community health at the University of Illinois at Urbana-Champaign. She leads the Aging, Caregiving, and Technology Lab, where her lab studies policy and technology to support family caregivers and their older relatives, with an increasing focus on Asian American caregivers. I'd also like to introduce Dr. Ronak Trivedi, who's a clinical health psychologist, an assistant professor in the Department of Psychiatry and Behavioral Sciences at Stanford University, and an investigator at the Center for the Innovation to Implementation at the VA Palo Alto Healthcare System. Her NIH, VA, and foundation-funded studies are focused on improving the self-management of serious illnesses by enhancing the collaboration and coping of patients and their caregivers. Dr. Trivedi is a Sojourn Scholars leader, and she is using this platform to improve culturally concordant care for South Asian women with breast cancer and their caregivers. Dr. Trivedi serves as the Director of Training and Education at the Center for Innovation to Implementation at the VA Palo Alto Healthcare System. She's Site PI and Training Director for the Elizabeth Dole National Center of Excellence for Veteran and Caregiver Research, as well as the Director of Caregiving and Family Systems at the Stanford Center for Asian Health Research and Education. I'll leave it to you both, Drs. Trivedi and Raj.
Thank you so much, Dr. Cothran, and thank you for everybody who has already shared the amazing work that has come out of this report, and allowing Dr. Raj and I to present our work. I'm going to kick us off and then we'll just kind of pass the baton back and forth. Next slide, please. So Lauren alluded to this a little bit, but this is what Asia looks like. Asia comprises 48 countries with 71 official languages, and it covers 17 million square miles. Next slide. And this population covers about 60% of the world population, and these are data from a few years ago now. And as you can see, 59.4% of the world's population identifies as Asian. And click, please. However, when you look at global participation in clinical trials, one of the ways in which we do research, you can see that less than 12% of Asians are represented in clinical trials globally. So as you can see, that Asians are typically not involved in medical decisions that are made for them. Next slide, please. So we have two sets of projects that we would like to highlight. One is Dr. Raj's work, and then she'll pass it back to me for us to talk about our work. So we can share from the field, as Dr. Cothran said, some of the work that is ongoing. Dr. Raj?
Thank you so much. So I just wanted to present a couple of findings from two of my studies that we're working on in the Aging, Caregiving, and Technology Lab at Illinois. So the first study is about Asian American family caregivers and their role as what I call sociocultural navigators within the healthcare system. So these are caregivers who help their older relative navigate things like language, diet, and as we found in the study, they also help navigate issues of discrimination, traditional medical approaches. And to Dr. Trivedi's point about clinical trials, one of the things that came up in our study was that family caregivers are concerned about language of clinical trials, about the increased burden or demands or responsibilities associated with caregiving when they have to not only transport and help manage medications and side effects, but they also have to navigate language differences and dietary differences and cultural differences. So this was a qualitative study with 40 Asian American caregivers across 9 subgroups. So including, for example, Pakistani, Indian, Vietnamese, Korean, Chinese caregivers. And so based on the findings from this study, we are developing a quantitative survey that we hope to field in the next couple of months. Next slide, please. Another study that we're working on in the lab is related to implementing inclusive foods in long-term care facilities. So this work actually emerged from the study that I just summarized very briefly for you, where we found that caregivers are very much involved in meal preparation and commuting those meals to long-term care facilities, which don't offer culturally inclusive foods for immigrant or minority older adults who are in those settings. And so what we did here is focus groups with long-term care staff, and we're currently developing a survey with dietitians to learn about some best practices for implementing inclusive meals. And so the areas of concern that we're really trying to target here are to reduce caregiver demands associated with meal preparation, to supplement the long-term care facility offerings, and to develop inclusive organizations. And some of this work may be applicable to hospitals and other types of settings as well, where caregivers from these communities are often tasked with filling in gaps that the system has, and they're not compensated or recognized or supported in those efforts. And so there's a steep learning curve, for example, understanding ingredients and understanding substitutions in meal preparation that are not necessarily explained to them. So the goal of both of these studies is to understand how can we better support caregivers and how can we create a healthcare system that doesn't demand so much from caregivers without providing them the support that they need to actually carry out those responsibilities. Next slide, please. So just a few takeaways. I wanted to highlight this quote from the World Health Organization, which says, evidence from research can improve the health policy process by identifying new issues for the policy agenda, informing decisions about policy content and direction, and evaluating the impact of policy. And so the idea here is that a strong evidence base is, first of all, fundamental to policymaking, but it's also fundamental to good policymaking that is sustainable, scalable, and applicable to diverse populations. And the issue we have here is that data on Asian Americans is very sparse. So finding data on Asian Americans in surveys is challenging and limited. And even those surveys that include data on Asian Americans tend to have very small sample sizes, where it's difficult to make inferences that can inform policy. And related to that, we have very limited disaggregated data on subgroups, meaning that Asian Americans are often represented in data sets as one large group without distinguishing between the cultural nuances of those different subgroups. And so developing good policy requires, first of all, enhancing research that really addresses these different areas. So I'd like to turn it back to Dr. Trivedi so she can share her research.
Thank you, Dr. Raj. Next slide. So I'm going to talk about an ongoing project called SUFFERT, which is a South Asian Family Approaches to Disease. Next slide, please. This is a project that is currently funded by the Cambia Health Foundation through the Sojourn Scholars Program. And it's meant to have 3 phases. The first phase, which we're wrapping up, is a mixed methods study of 12 to 15 survivors, caregivers, and providers. And our goal here is to understand their unmet needs, both in terms of their emotional needs as well as home and community-based services. One of the speakers earlier alluded to this, and Dr. Raj alluded to this as well, that there's differences in languages and there's difference in cultural needs that are represented within the community. So for example, if Meals on Wheels were going to deliver meals, the meals would ideally be tailored to the needs of the community it was serving, and generally that often does not happen. So we are wrapping this phase of the project up. We just finished our interviews and are doing analyses. And our goal is to use this to develop some intervention and a prototype and then field test it. We are advised by currently 8 to 10 members of the community. These are people who represent different professions. These are non-academicians. They include a technocrat, a lawyer, a small business owner, and so forth. And they're there to sort of help us with our blind spots, make sure that we're doing work that is relevant to the community. Also, within the South Asian community, there's a lot of major religions that are represented. So our community advisory boards also are representing the major religions of the South Asian diaspora. Next slide. So what we have learned so far in our interviews, this is very preliminary, hot off the press type of information. The survivors have a high level of trust in their medical care teams and did not really perceive racism. We specifically asked about that. However, when probed, nearly everybody noted that their names were mispronounced and kind of laughed it off. And we know that this is a form of microaggression if people do not learn our names. So the racism sort of spectrum, the more egregious things are not represented, which is good to hear. But also we could do better in terms of learning people's names. We also heard a lot of struggle with diagnosis because a lot of them perceived themselves as low risk because they felt their lifestyle had been very healthy. They've been exercising, not really eating a lot of fried food, so forth, and did not notice any family history of breast cancer. So we're confused why they were diagnosed with this condition. Survivors also noted that there was a need for information that was both culturally relevant and was available in native languages. So the culturally relevant information were things like how to follow culturally relevant, culturally concordant diet, things that kind of factor in often the multi-generational family structures and so forth. And the survivors also noted a reluctance to share their diagnosis with family or friends, especially those in their native countries. So cancer is pretty stigmatized within the South Asian communities. And breast cancer is particularly taboo because it focuses on women's reproductive organs or reproductive systems. And this got reflected in our responses where the survivors themselves did not experience stigma. They had not internalized the stigma, but they were titrating the information because they knew that stigma existed. So for example, this person said, after I found out, I shared it with my sister-in-law, and one of my friends. I did have my in-laws at our house, but I did not share this information with them because I thought they might be too anxious or be more sad. I didn't want to share it with my parents or in-laws. So even though these folks are living with them, they don't know that their daughter-in-laws have been diagnosed with breast cancer. Next slide. From caregivers, we learned that caregivers often undertook the bulk of the cancer-related research on behalf of the survivor. And they noted that the support they received from survivors' healthcare team was not great, and they were not asked about their own emotional needs. This was probably amplified because coincidentally, our project started its data collection during the pandemic where caregivers at least locally, were not allowed to accompany patients to their various outpatient or chemo radiation visits. Caregivers also noted that they had multiple caregiver responsibilities and received little practical support. They got a lot of emotional support, but their social networks provided very limited practical support to caregivers. And this quotation, I think, is really great for all of us who are on this call because we're all at some level interested in caregiving. This amazing caregiver told us, people like you and others who are in this line of work, which is all of us, need to appreciate and understand that you're doing God's work. You're helping the patients, but you're not only helping the patient, you're helping everybody that's around the patient, their families, their coworkers, and to keep doing what you do and continue doing it with a sense of empathy. Thank you. Next slide, please. So to summarize, the cultural needs of Asians and South Asians in particular have been invisible in the healthcare system. Caregiving in these communities is complex and practiced in accordance with gender roles and cultural norms. And this is something that we need more research on, and that would help us inform policy. And as our elder population becomes more diverse, focusing on Asian and Asian Americans is important in supporting their well-being and creating policies that benefit them and are targeting resources towards them. Next slide. And this is our contact information if you want to get in touch with us. And I hand it back to you, Dr. Cothran.
Thank you. Thank you, Drs. Raja and Trivedi. I really appreciate that. And thank you to all of our speakers today. We've really had an opportunity to learn more about caregiving diversity and challenges, as well as opportunities from the varied perspectives of our speakers today. I just want it to be known that NAC has a commitment to look at caregiving across the lifespan, which includes the diverse community of caregivers that we serve. And for us, this report represents how we will continue to incorporate an equity lens in our research processes and work that reflects our nation to help inform research, practice, policy, and advocacy. And so at this point, I'd like to open it up for any questions, and in the time that we have remaining, begin engaging in a dialogue, supporting how we can continue this work to support our diverse communities of caregivers. So I know that there have been a few questions that have come in, and I know there was just a contact information slide. And for those that may not be aware, we are going to be sending out slides and materials shortly after the webinar, not today, but shortly after. So let's see what's happening in the questions and answers. All right, and some questions may have been asked along the way. All right, are there any, I don't think any of these have been answered yet. So are there any plans to expand and disaggregate research into LGBTQ caregivers in the future? Well, I certainly think that that's something that we're going to want to do. Can you say, well, I guess you can't say more about it, but yeah, we want to make sure that we're looking at perspectives in as depth of a way as possible. And so while we don't have a plan yet, we're going to make sure that we're consulting with all of our partners so that we can do it thoughtfully and well. So thank you for that question. I hope that that answers. What languages were used to collect data? Okay, thank you. What languages were used to collect data? Many large studies are conducted in English and Spanish only, and many AAPI caregivers speak many different languages. For those whose first language is not English or Spanish, how can they participate in the study? I think that's a great question, and I'll actually open that up to, let's see, when we collected this data, it was done in English, I believe, English and Spanish.
Yes.
Yeah. And so I think as has been presented by many of our panelists and speakers today, we know that there are a variety of languages. We know that there are limitations in what people's English proficiency is. And so we'd like to make sure that we move that forward. But at present, the study reflected work that was done in 2000, that was collected in the 2020 report was reflective of caregivers who spoke English and Spanish. So we do want to do something different. Any significant variations identified among the groups discussed in this report as far as short-term and long-term conditions? And I think that'll probably be Reed and or Paul, if they'd like to jump in and say anything.
Yeah, happy to take that one on. So the focus of this report, we didn't look at variations within those particular categories, but definitely something to consider looking at for the future is breaking those categories out.
Thank you. And I love this question. I love all of the questions, but how are researchers staying motivated after seeing so many public health apparatuses fail to adequately respond to COVID in so many countries, states, and cities? And I'll actually use that to kind of jump in and open it back up to all of our panelists who've had experiences with their communities who are caregivers, as well as the researchers as well. I think that this crosses over. So with that, actually, if we'll go backward, Dr. Trivedi or Dr. Raj, if you could jump in and start, and then we'll kind of go backwards.
Sorry, which question for the how do we stay motivated?
Yeah, especially in the context of COVID and how we've seen so much fail, the systems that have been failing our caregivers.
I think that it reminds me of all the work that needs to be done. And I think that to me, it sort of feels like, okay, we see the fault lines in the buildings we build, and we have a way that we can change our corner of the world, which is focusing on the needs of caregivers. And I think the time is now really right and ripe, because so much now has been written in the public media on the importance of caregivers of all kinds, not just the type of caregiving that, for example, I study, which is of people with chronic and serious health conditions, but parents and teachers and healthcare providers and so forth. So I think this is up on top of people's minds. But I also echo the feeling that you may have, whoever asked the question, that it's hard. And I think taking breaks and knowing that we're playing the long game and it's not a sprint, but it's a marathon, also helps sort of keep us centered and motivated. And
Dr.
paying
Raj?
it forward. I find paying it forward. So I do a lot of mentoring and teaching. And I think, doing that can be very energizing as well. Sorry, fun.
No, that's okay. Excuse me. I was just branching out to Dr. Raj to see if she had anything to offer.
Sure. I mean, I think seeing public health failures has definitely been discouraging, but also in a way is itself motivating, because it just shows how much work we need to do and the value of collaborating and interdisciplinary work, because we're seeing that the issues that we're seeing span so many different disciplines. And so I think that there's a lot of opportunity for incremental, steady change and work in this area.
Dr. Cruz, do you have any comments that you would add? You can jump in if you, whenever. I'll jump to Reed in case there's anything that Reed or Dr. Barr would have to add to how to stay motivated.
I think one of the things that helps me stay motivated is these interdisciplinary partnerships, and knowing that the research isn't just getting pushed out there and not read or not used, but that it's actually being used to inform policy and that people are listening.
Yeah, I mean, I think for me, what keeps me motivated is staying connected with the community I serve. I mean, we have the great pleasure of having our office in a housing facility for older adults. So we get to see the challenges they face pretty regularly and the challenges caregivers face. So I think that is an inspiration for us, staying in contact with the people we served, with the voices we represent. I think it's important, and it is surely an inspiration. beyond that, I mean, having taken care of my own mother and having been a caregiver is something that will remain with me for the rest of my life. And that surely is a source of inspiration. I know when I took care of mom, you know, it was such a struggle and it was so overwhelming. And that just made me realize, imagine how difficult it must be for someone who doesn't understand the system, who is not in the aging field, and who doesn't speak the language. And so it was difficult for me, for my brother, but imagine how difficult it must be for families who just don't have the know-how or are not who don't have friends and colleagues who can advise and help. So I think, you know, helping others navigate this system is also an inspiration. Just being able to be a source of information for others, and it's just an important thing. You know, making a difference one person at a time, I think is important.
Yeah, I think I would just add, you know, what's been inspiring is just saying, you know, the public health success of developing the vaccines in the time frame that no one would ever thought imaginable, and having that ruled out. But I think it's what's been highlighted is the inequities and how that has been distributed, both here in the US and in other countries where, you know, I was getting a shot in my arm, one of the first people I had imagined proportionally in the States, when there's my family members back in Ireland didn't get a shot for a year later. And so that's incorrect. But what was encouraging was seeing how people rallied to support those where these inequities existed, going grocery shopping for a neighbor who couldn't go out otherwise because they were at risk. And those little things that were really encouraging. So that certainly helped maintain motivation.
Well, thank you. Thank you for everyone for sharing their perspectives. And I realize that we are literally 1 minute over the top of the hour. So with that, I will just say that thank you to our panelists. I hope everyone in the audience will join me in thanking all of our speakers today. And I do think that this is still the beginning of a conversation. We want to move toward action. And so continue to reach out, continue to stay engaged, as we will do our best to do the same, or we will do the same. But thank you to everyone. Thank you for those who've joined. And we look forward to hearing from you again, and just enjoy the remainder of your afternoon. Thank you, everyone.